All right, let's get going. I'm sure there'll be a bunch more people signing in. Um, Anybody here from the healthcare district? Dr. Andriek, are you with us?
Don't believe she's gonna be.
There may be some people who don't care to chime in on the legislative side of things. After all, it is sausage making. Dr. Atenito from FAU, College of Business Health Administration. Dr. Atenito. Tom Baird, attorney, Jones and Foster, city attorney for a number of cities. Okay, Turner Benoit, I saw Turner, you're here from Hanley.
Hi there.
Ariana Ciancio, Delray Beach PD. Uta Gasiak, are you with us, Uta, from the Florida Behavioral Health Association? Would you reach out to her and see if she's planning on coming? Thank you. Okay, I don't think Lori Holtzclaw Hunt could make it, but I saw Michael McKeah. Michael, are you with us?
I'm here.
Are you going to represent for Oxford?
Absolutely.
Okay, off the top of your head, do you know how many Oxford houses there are in the country? Okay.
Over 3,600 at this point.
3,600? Thank you. And beds approximately?
Oh, I don't know. It's around 30,000, I'd imagine.
Okay, very good. Okay, thanks. I won't hold you to those numbers, by the way. Okay, John Hewlett. John, are you with us? All right, Heidi, I thought I saw Heidi Matheny. You with us?
I am. Hi,
From
Al.
FAR?
Hi, everyone.
Thank you. Kelly Lee from the department, DCF. Kelly, you with us? Would you reach out to Kelly and see if she can join us? Thank you. Jeff Lynn, I saw you just signed in. Jeff, you with us?
I'm here.
I guess one of the foremost experts that I know of on the DCF rules. Anyway, Nancy McConnell, CEO of Rebel Recovery. Nancy, are you with us? Neil McGarry. Neil, you with us? Reach out to Neil as well. Okay, I know people are still signing on. Oh, Uta, are you with us? Okay.
Sorry, had to find my mute.
Oh, that's okay. Thanks for joining us. It's important that you're on this meeting. Okay, I know Dr. Moran is under the weather. He apparently sent some suggestions regarding the ratio on on recovery residences that are level 4s. Okay, Dr. Needle, Rachel Needle, are you with us, Rachel? Houston Park. I thought I saw Houston. Are you with us? Okay. Terrell, I saw Terrell Pyburn, Coconut Creek City Attorney. And you still working with Delray?
I do still do consulting for Delray, yes, on the issue of recovery residences. Good afternoon, everybody.
Susan Ramsey. Susan, are you here? Hi, there you are. Terry Shapiro. Terry, are you with us? GIA Miami and Vita Recovery. Terry. Nikki Soda. I saw Nikki, NAATP.
I'm here. Hi.
National Association of Addiction Treatment Providers.
Providers.
I'll
Very
get
good.
that. I'll get that right. Okay. Let's see. Dr. Semenides, John Semenides, are you with us, John? I think I'm getting a trend here. A lot of the medical profession, when you're talking about legislation, it's like, nah, I'm out. Okay, Alton Taylor, Drug Abuse Foundation. Alton, are you with us? Okay, Jan Toman, Project Opioid South Florida. Jan?
Good
There you are.
afternoon. Hello.
Good afternoon. Dr. Vinicor, Lori Vinicor, I saw you. There you are. Alliance of
Yes,
Del
here I
Rey.
am.
You had a
Yes.
great crowd at your first live meeting the other week.
Yes, it was great. Insurance, talk about insurance.
Talk about insurance, the public comes out. Talk about sober homes, the public comes out for sure. Jennifer Webb, Floridians for Recovery. Jennifer's not here. Okay, I know Mayor Weiss is not here, but I believe, do we have somebody from Mayor Weiss's
Yeah,
office?
Niels is here for Mayor Weiss. He'll be
Oh.
joining in a little bit. He should
Okay.
be joining us later.
Thank you, Nils. Okay, Richard Worms, I saw you were on from the AG's office.
Hopefully you can hear me.
Thank you. And Eric Urlano, Integrity Billing. Eric, you with us? Thought I saw him. Okay. Lastly, Representative Mike Caruso. I don't think he could make it, but Walter, are you with us?
Yes, I am. I got a hard stop at 1:45, but otherwise I'm here.
Okay, well, we should be through a lot of this by 1:45.
Al, I just joined. It's Rachel.
What's that?
I just joined. It's Rachel Needle.
Oh, okay. Thanks, Dr. Needle. All right. Well,
And-
welcome, everybody. We're doing legislation today, but the first thing, order of business, is I just want to go over a couple of things on the best practices for recovery housing released by SAMHSA. It's really good, and it takes us in the right direction. I think one of the ultimate goals with regard to housing is to get the payers to start recognizing that housing is a critical part of recovery. And SAMHSA in their new report, updating from the one that was in 2019, which was kind of a little milquetoasty, but this one it has a lot of good stuff in it. One of the things they do in their introduction is they talk about how critical housing is for long-term recovery. And they use some statistics as well. The more statistics we get, the more the economic benefit for payers will become to recognize not just inpatient housing, but your long-term continuum of care. So hopefully we'll see that in our lifetimes. Now, one of the things I wanted to bring up, which is really interesting as a statistic on page 1, is the numbers. They talk about, this is on page 1 and page 10, but on 1, they talk about 17,943 recovery residences in the U.S. I just asked Mr. McKeel from Oxford House, and there are 3,600 residences, and there are 2,500 certified recovery residences through NAR nationwide. So it looks like the majority of recovery residences in the nation have no affiliation with best practices through NAR or with Oxford House. So that's one interesting thing to look at. I think that's going to change, hopefully. It should change. But I was noting that of the 2,500 certified recovery residences in the country, and they said 25,000 certified beds. I guess that's an approximation. FAR with 8,500 has 34% in Florida of the total number of NAR beds nationwide. That is incredible. We are a model for the rest of the country, and hopefully that model is going to rub off on a lot of other states. But I just thought that was interesting on pages 1 and 10. And based on my count, only 14% of recovery residences are certified in the country. Actually, adding Oxford House onto that, it's probably around 70% are not certified. Okay, on page 10, just want to make note of the fact that SAMHSA is talking about the importance of certification. I'm sure they mean both certification and recovery residences that are recognized by Congress, like Oxford House. But it's talking about the importance of certification as a best practice. That's why I think the bar will be moving nationwide. Hopefully the states will start taking some action like we have here in Florida to entice or cajole, whatever word you want to use, recovery residences to become certified. We have a movement now through zoning, and that's part of the statewide zoning study that we're going to do, which will really kick certification and Oxford housing up in other parts of the state where there may be reluctance. So the third thing I wanted to talk about, and we'll be talking about this in the legislation. I'm gonna pose this question: the NAR levels versus the FAR levels of support. So both FAR and NAR have 4 levels of support. I want to pose this question because in Florida, our level 4 has no clinical aspect. There's no clinical in the home specifically, but in the NAR level nationwide, there is on-site clinical services. When we get to that first piece of legislation, I want you to think about it for a minute, and I want somebody or anybody or all of you to chime in on why this is. Why are we looking at our level 4 differently than the level 4 nationally through NAR? Because some of this legislation actually codifies in statute the definition of recovery residents to include levels of support. So, okay, in a few minutes. So before we go down that road, I want to really flesh that out. The last thing that's on this is on page 11, which is really supports one of the pieces of our legislation that we'll be discussing today, which is MAT as a best practice in recovery housing. So SAMHSA, it's their recommendation, okay, that MAT, there be no barriers to MAT in recovery housing. I think it's on page 11 and page 12, if I'm not mistaken. But anyway, any comments or questions about SAMHSA's new release? Came out a couple of weeks ago. Thank you, Jeff, for sending it out to everybody. Any comments? And please raise your hand if you do. And are you looking to see if there's any hand raised?
We did, but I think.
Great.
Oh, Dr. Saucer has a hand raised.
What?
Dr. Saucer has a hand raised.
Oh, Dr. Schlosser, please. Mark, what do you want to share with us?
Yeah, I wanted to, hop on the meeting just to make sure that the medications, were included and that the language was broad enough so that it would include, all medications that are legally prescribed for any SUD. I mean, I know here it focuses on methadone, buprenorphine, and naltrexone, but there are other medications that are used and, not necessarily controlled medications, but there shouldn't be, anything that's legally prescribed should be allowed.
Let's wait till we get to that part of the legislation, and then we can have a full discussion because it speaks for itself. And I think everybody should have gotten a copy of the drafts and updates, hopefully. But let's go to the first piece of legislation on your agenda, everyone. And Dr. Schlosser, I will make sure that that you have a chance when we do discuss that specific piece. I think it's 391, 397, 487, subsection 8. Okay, the first one on our agenda is statute 212.02, definitions. And what's been happening in some of the local jurisdictions is that they've been getting confused about recovery residences because in some recovery residences, especially level 4, level 3, there's a turnover. It's more short term than level 1 and 2. And they've been starting to or attempting to treat these recovery residences like either board and care or like hotels or Airbnbs, which is basically violates federal law. So to make it so that there's no misunderstanding, for the purposes of leasing, we have legislation here that exempts recovery residences as defined in statute. That rent properties for these purposes are not subject to any taxes imposed on transient accommodations. And then there's a list of the various ones, including convention development taxes, tourist development taxes, locally imposed discretionary sales surcharges. That does not mean that normal local taxes that are collected on any residential property are not collected on these properties. These are special taxes that are imposed on transient accommodations. So, any questions on this? Any recommendations? Okay, let's go on to
Al, this is Tom Baird.
Tom.
So I'm sorry, I joined after you got through the beginning of the alphabet. It's not the intent then for this section to cover something like a business tax receipt, because I know some municipalities for leased properties assess a business tax receipt.
It's not my understanding that this would apply to business taxes, only because it is a business. So it should be treated, as you know, the violation of federal law is when you treat these properties differently or the residents differently than the ordinary course. Now, obviously, it's a business that's allowed in a residential area by federal law. But I don't see any of this, and anybody else can chime in. Jeff Lynn, if you have a difference of opinion, but this statute does not include business taxes that would normally be incurred. It's
That's
the
correct.
transient
It's
taxes.
not intended to. It's simply Tom, the bed tax,
Right.
the tourism tax. That you
Okay.
see that and the reason that we're clarifying this is because you have tax collectors in various counties, right? Their jurisdictions, they've all come up with different interpretations, either as a cudgel or because they're just uninformed. And FAR gets those calls all the time. They always get funneled to me. This actually was somewhat resolved locally in Palm Beach County, but never definitively. And it's creeping up again. So it's simply, especially with the Airbnb question, it's simply like this is not a transient use of property that otherwise would allow for a taxing authority to tax it as a transient use for purposes of those specialized taxes, which the cities don't get anyways. It goes generally always to the county for purposes of promoting tourism.
Thank you, that's helpful. I just want to make sure I knew what the answer to that was when I get asked that question.
But also if there's any sales tax, Tom, there's often a sales tax on leases. That still applies. Anything that would normally apply, to the rental of a home, if it's rented, would apply. It's just those additional discretionary taxes that are just, again, the only people who would complain would be like the local tourism board who just wants more money. You know what I mean? And I don't mean that negatively. I mean, that's the only entity that this is affecting.
I understand. More money for baseball stadiums.
And quite frankly, in legislative speak, it specifies those sections. It doesn't say including but not limited to, which would then put other sections in doubt. But these are the 4 sections that it targets. So Yeah, it's not, it doesn't extend beyond that.
Okay, that addresses my question. Thank you.
Okay, let's go on to number 3. We can start our discussion about level 4 in a minute, but basically what this does, section 9 added to definitions, is it gives a definition of community housing, which is meant to define level 4 FAR or NAR level of support. There's one thing that I'm going to add to the end of this, and plus the fact, release the,
No, you have.
yeah, okay, good. First of all, we cannot talk about Florida Association of Recovery. We ought not, I don't think we can, in legislation, because as far as the Florida legislature is concerned in statute, it doesn't exist. It is the certifying entity that has been contracted by the department. And it's not, department could tomorrow change to another certifying entity. Number one, we need to take out under the Florida Association of Recovery Residences, which I'm going to do now. And meets the definition of community housing under hang on. Okay. Classified as a level 4, a 4 level of support as defined. Now this presupposes that we are going to have the 4 levels defined. One of the problems with listing a level 4 in statute right now, and I can tell you this is going to get kicked out by staff, is there's no definition of level 4 anywhere in Florida statute. And we do have day or night with housing and without housing, but it doesn't specifically talk about level 4. So this is provided that we all can agree, or well, actually, that Dave Ehrenberg, the state attorney, is okay with defining the 4 levels under recovery residence. But we'll talk about that in a minute. Sorry to be confusing, but as defined in S 397.311 and then 38D, which we will be discussing later. So if we do have that legislation to propose on the 4 levels, then this will apply. Otherwise, we'd have to go to some other type of plan. But anyway, any comments on defining community housing, which is in effect defining what is currently level 4 housing? Okay, let's go on to number 4.
Sorry, Al, just
Yes.
really quickly. Do we want to say off-site at the end of the sentence that's defining community housing? It's a rather long sentence before you get to the part where it says a recovery residence used by a licensed service provider. Only because that goes along with what you pointed out earlier, is as part of what distinguishes Florida under FAR from NAR is that the clinical services are not provided on site.
It says it like, I mean, I'm not trying to be difficult. It's so many people have gone through this definition. FAR's had like 10 meetings on it. You could put it in there, but it's like, man, like the sausage making is getting ugly.
Well,
You already say
I don't
outpatient
think-
care services. I mean,
yeah, I don't think
it's inherent what it is. It's not a zoning definition.
and we do, if we do the 4 levels, we do define it with no on-site.
Right.
So
Okay, that's
we
fine.
reference
It was
level
just an
4.
observation.
Okay, Uta, you've got your hand raised.
Yes, hi. I'm just sort of wondering, Alex, explain to me again, I think sometimes when you put things like this in legislation, it makes it's just a lot of detail to actually have in legislation. When things change, let's say NAR changes their standards in a couple of years, are you going to go back, And I agree with the previous comment, 4 is definitely going to be a licensable component under other parts of the law. So what is the purpose of actually putting the 4 levels into chapter 397?
Hey, anybody want to comment on that?
I'll start. Hi, it's Jeff Lynn. How are you? So going back a while ago, and again, in discussions with the FAR board and other providers, and providers that are on the meeting, and a lot of people that have contributed from the sector, is that the FAR level 4, okay, whatever the world wants to call it, what we call the Florida model, is now becoming the adopted, accepted healthcare model. Growing and growing, being accepted by insurance. They're not paying for the housing, but they're recognizing the need for what we're defining as community housing, or what used to be a long time ago, residential level 5, which which we should probably bring back as a licensable component. But in order to start having insurance recognize lawfully that the housing is a component such that it needs to be compensated for, no differently than when you're at a hospital, the hospital room needs to be compensated for while you're getting the procedure, so to speak. By creating a definition that incorporates level 4, we start to incorporate the Florida model into our into Florida speak, such that when insurance is writing their policies and the argument starts to be asserted that they do need to cover what we're calling community housing, and it's part of Florida law, then we believe, based upon recommendation and advice from others, that this is the necessary first step to having insurance recognize the Florida model as a reimbursable modality. So that's number 1. Number 2 is that because the FAR standards, because the NAR standards are different in kind than the FAR standards, and that's mostly because level 4 under the NAR national standard is the equivalent of Florida's inpatient treatment, just in a house. So because we have a separate license for inpatient treatment and DCF licenses this, FAR spent significant time detailing the distinctions between a 1, 2, 3, and 4, and realized that there are a lot of providers in the state through prior evolutions of the FAR board or whatever, that had we believe, a misinterpretation of what a FAR level 2 versus a 3 versus a 4 is. So the FAR board wanted to be very clear that if you are an IOP provider or above, IOP day or night with community housing, clearly with the community housing license requires that you have housing. So it falls into this neat umbrella here, but we're really talking about any housing provider that has IOP or higher, and they are the ones, the treatment providers providing the housing for people that are in their treatment program that meet that placement. FAR has decided that based upon the standards, the oversight standards, the staffing standards, what's in the patient's best interest, that those homes should be a level 4 based upon how FAR certifies level 4 homes and what they expect from those providers. So what the statute does, in addition to starting to incorporate the idea of what a level 4 home is, particularly with now SAMHSA incorporating NAR as national best standards, we feel we have even better standing to start incorporating these 4 levels into state statute, because I don't think NAR is going to change anytime soon. NAR didn't come out of thin air. NAR adopted standards that have been in place by GAR and other states for many, many years, as you know. So assuming that SAMHSA has adopted, which they have, as best practices, the NAR standards, and the FAR standards are based on NAR. So we wanting to meet the NAR standards, start adopting those. We want to start to identify what is this, and we call it community housing in a nod, tip of the cap, to the day or night treatment with community housing license, so not to confuse anyone. So yes, we mean that kind of housing, and it also means any kind of housing where you require your patients to stay there. That under FAR, under their authority to regulate the housing side of that equation, they believe it's a 4, and to avoid any other internal confusion amongst certificate holders, licensed housing providers as to a distinction, we now have a statute to point to say, look, we can fight about this all you want, Mr. Housing Provider. Under the state's definition, you're a 4. We're treating you like a 4. You have to staff it like a 4. You have to treat your patients as if they're in a level 4 program. So that's the purpose of this statute, of this definition, to create this a whole, you hope to be a stone running downhill that, you know, really ultimately gets us to the end game, which is recognizing that some levels of housing need to be compensated as part of the full healthcare model.
And I
So are you,
would also add,
I'm thinking you're addressing mainly private insurance, since Medicaid doesn't typically pay for room and board. I mean, they don't even pay for residential treatment.
the goal, Jeff, let me, because I also want to make another comment, but the goal is to have Medicare and Medicaid recognize housing as a critical component of treatment. So, and that's pretty much, if I understand the way the system works, and I could be wrong, it's pretty much the way it starts through Medicare and Medicaid, and then the private payers come over. So this is part of a long-term approach to try to
Just
get
so you
that
know,
done.
that's more on the federal level. So, you know, I'm not sure that Florida statute's gonna have much impact on that.
Okay.
So,
Because
That's
room and
fine, but
board
we're-
is
but
typically
we're-
not
but
something
Hang on,
that they.
hands, please. Tori,
Honestly, but
grab your hands.
the comment was for the private
Yeah,
providers. Yes,
yeah.
for private providers, this is important.
please. We'll come back to you. Raise your hand again. Tori, you got your hand raised. Go ahead.
Thank you. Yeah, well, even within a federal system, especially when you're talking about the exchange program, the states play an intricate role within that system because many of the payers, if not all, are considered federally chartered, right? You could have a smaller state to state operator, but if you're talking a large payer, you're going to have individuals that are voluntarily joining your exchange programs, which are going to work within state licensing systems. And so this actually does integrate both in a state and federal model, just based on the model that federal insurance, as well as what we all call Obamacare, you know, on the sideline, but is called the exchange program when people look at it from its more official title. So it does involve both. And then remember, Medicare, Medicaid is a single side of it that is combined with the managed care plans, which still run through the private payers. So as Jeff pointed out, through the private side of this, this is an extremely important aspect to get right.
Okay. Uta, I think you were talking and we interrupted you, so go ahead.
No, it's okay. I'm good.
Okay.
Thanks.
And the other thing that you did mention licensable components, and if it was true that all intensive outpatient was licensed by the department, then yeah, we may be having a different discussion. But this includes IOP and anything above, including day night without the housing. So, all right. Any other comments or questions on 397, 311, 9?
Al, I just have one comment. I mean, I support what Jeff is saying. I mean, this is what FAR has been working on for a while in terms of getting clarification to the providers also, because there is certainly confusion. And I would give the benefit of the doubt as that is what's happening, but there are facilities that really are, have been certified at a level 2 that really should be a level 4. And so part of this is all a way to educate those who are, attempting to do it correctly. And the definitions help define what kind of patient population you have in each level. and what they require. So it's as clear as it can be. And I think that's really important because that's part of the issue, is clarifying the confusion for the providers as well as potential payers and the rest, but to comport with best practices as well, the difference between a 1, 2, 3, and 4. So I think this really does take a big bite at that and moves forward to that. So that's my comment.
Okay. The one thing I haven't raised, and I'll put my prosecutor hat on, is, and one of the reasons why I started out being a little skeptical about this, is I don't want to open up the door to patient brokering, because this is a system in level 4 where the residents are required to stay in the house owned by the provider. And so FAR is really going to have to be vigilant in making sure that patient brokering isn't occurring, that there aren't inducements such as free rent and extras that are basically bringing back the bad old days. I think we're beyond that. I think our laws have formed a wall somewhat. There's still patient brokering going on, but it's a different ilk. Any other comment? Uta, you have your hand raised again?
Yeah, I have one more question, Al. Thank you. For the level 1, where it says a minimum of 9 months sobriety, has anybody worked with Oxford House on this in terms of the definition? Since I don't believe they require that, and they would obviously fall under the 1 here.
Okay, Uta, let's talk about that when we get to that statute.
Okay.
And that's a valid point, because I had the same concern, but that's directly out of NAR. So I got it. But I said 9 months. It's like not 9 months in one day, not 8 months and 29, So maybe that ought not be codified, but let's have a discussion. So let's go on to item 4. Okay. Let me describe what we're doing here briefly, and then I'll get everybody's input. First of all, when you go to 397, 487B, we're upping the number of days. If there's a termination, resignation, or a CRRA leaves, one of the issues that everybody's aware of is the workforce shortage of CRRAs, and we all recognize that. So this is to give a little more flexibility to retain a certified recovery residence administrator to replace one that's gone. And the other thing requested by FAR, well, I don't know that this was actually requested by FAR, but it came up in conversation and some of the previous meetings about, when you say shall, you have to do it on the 91st day. And FAR has been historically very attuned. I won't say aggressive, that's not the right word, but they've been there is a substantial amount of oversight. So there are cases where it might take longer than 90 days even, but if the place is functioning well, there aren't complaints, there aren't bad things happening, they should have the ability, so long as they have specific policies of extending. So this says may instead of shall. I don't know if anybody has umbrage with that. Okay, we have a raised hand. Will.
Hey everyone, my name is William Atkinson. I'm a board member with FAR and also a board member for Floridians for Recovery. There are opportunities to take a page potentially out of the peer support language. If we were to say that a CRRA was working to gain the hours through FCB, does the committee or this group think that would satisfy the needs of supplanting a CRA, meaning they have somebody in training for that process. That was just a thought process to share.
I think we already have a CRRA and training section in the bill. Not prepared, don't know exactly where it is. But okay, let me make a note of that and to consider. I'm gonna take a page from Uta's playbook and say we don't want to do too much. But Neil McGarry is the person to talk to about this, about at what point would somebody be qualified and be able to do it while they're working toward their certification. I thought we had that in there, but I'll look into that. Any other comments so far? Okay, C is the new first half of C. If a recovery residence is certified recovery residence administrator has been removed due to termination, resignation, et cetera, and had been approved to actively manage more than 50 residents, the recovery residence shall have 90 days to retain another certified recovery residence administrator pursuant to that section. Now, the need for this is, and I'll ask somebody from FAR to answer.
Are you on? The need for why the revisions being requested?
For C, yeah, for the first half of C.
Well, the first half of C, meaning
The underlying
the
portion.
second half of C. Right, right. So right now, or last year, the year before, whenever, it used to be that state statute required or limited CRRAs to no more than 3 residences. And then the task force recommended and the legislature adopted in 2021, maybe, that a CRRA could oversee 50 residents, beds. And that was, candidly, we all agreed was an arbitrary number. We wanted the number to increase based upon certain metrics that is coming in a different statute for level home, specifically for level home providers. But for right now, all providers can seek to go up from 50 to 100 under existing statute, meaning 100 beds to supervise if you meet certain criteria. So what this says is if you have a recovery residence, and to be the match was earlier, it's going from 30 days to 90 days. One of the biggest reasons for that, and the reason given when we first met, was we're having a workforce issue with identifying competent and capable CRRAs. And so it's causing an artificial depression on the ability of treatment providers in particular to provide housing for their residents, because you have to go out and find more and more CRAs which just don't exist readily. So what this does is, in conjunction with the other section, in addition to raising that cap on very limited circumstances, this says is that if you were if you're a treatment program and your CRRA is the one that qualified you to go from 50 to 100, and then that person leaves, you fire them, whatever, you don't lose that ability to go. You don't have to automatically relocate if you have 100 beds, 50 of your beds, because your one CRRA can only oversee 50. You have 90 days, like the other 90 days, to find a new CRRA without compromising your program. So if you took advantage and FAR has approved you for more than 50 beds, if you lose what I call the qualifying CRRA that qualified you for more than those 50 beds, if that person is terminated or resigns, you don't lose that benefit right away. You have to find a new CRRA to replace that one. And that new CRRA needs to qualify for the additional bed count too. They have to go through the same process. But this just maintains the status quo until that happens.
How is
Does that make sense?
How is this not done with B, where we increase from 30 to 90 days? I mean, that's a general for any certified recovery residence administrator. Why do we need a specific one for somebody that actively manages more than 50?
Okay, so let me back up. If you don't have any language in there, if you don't put this in there, and someone who has more than, you're my CRRA, Al, right? I'm a treatment program, or I'm a housing provider, but you're my CRA, and you've qualified for more than 50, you've qualified for 100, and now I either fire you or you leave, can I still keep the 100?
Well, isn't it FAR that qualifies from 50 to 100? It's the certifying
CRA. That
entity.
CRA just left. That CRA just left. So now, what's the answer now? What do we do now?
Well, the answer would be that the person replacing would have to get FAR clearance to the certifying entity to clear for 100 persons.
Right. So in the interim period, from the time that CRA is terminated to the time I find a new one, am I allowed to keep the delta, the difference between the 50 and the 100, up to 100? Am I allowed to keep that while I look for a new CRA, or do I lose that because my CRA is left?
Okay, but both B and C are 90 days. You don't have 180 days. You don't have an extra 90 days. It's 90 days.
No. Right. I know that. I'm saying
so in other words,
isn't about the 90 days. Go ahead.
Okay.
Maybe someone could say it more artfully than I am, because I don't. I mean, I'm not Tori. Maybe
I see this as redundant. I put it in here because I received this suggestion, but I haven't heard how this is not redundant to be. And again, I'm gonna rely on Uta's comment. I'm gonna paraphrase: less is more. If you don't need to write additional statutory language and you're covered, you're covered. So unless
look, if we can get an opinion from FAR now or anyone that if you lose that CRA, we're not making you get rid of people, then this isn't necessary. You're right. But you know what? Without affirmative language and the way that the statutes that were originally written and proposed by Representative Hager and I can't remember the Senator Clemens from Lake Worth, was very restrictive on recovery residences. We've seen that historically. There's been a lot of restrictions placed against CRRAs and recovery residences that are not placed on other similarly situated healthcare providers. So we're starting to eliminate those artificial barriers. And so we just wanted to make sure here that if someone loses this CRA, that someone's not going to say, oh no, you lose those 50 people, when it's not clear. It's just simply not clear.
Well, I don't agree that it's not clear, because you have 90 days to retain a certified recovery residence administrator. That would mean somebody to replace the one you have. So if the one you have has 100 days, you have to replace with somebody with 100 days, and you got 90 days to do it. And you have 90 days under B, and you have 90 days under C. So again, let's not beat this to death. I'm inclined, I'm going to recommend it to Dave that we don't need the first half of C. Actually, we don't need C at all. We'd move the others up. But, I might think about it. As you said, any of y'all can call me up and tell me why that B doesn't cover what we're trying to do, which is actually be flexible. Number one, 90 days instead of 30. That's in B or C. And number two, may rather than shall. I think the way the system is working right now and the intent, because the certifying entity, which is right now FAR, there's no benefit for FAR to not be flexible in the may as opposed to shall, or to not speed up the process, but include the process with 90 days to be able to extend somebody's certification from 50 to 100. See, Tori, you have your hand raised. Go ahead.
Yes, and I think everybody agrees with you, and including, and I know there's other people from FAR here. I believe Susan's here. I think Mike Schlossman, Josh, and Heidi. You are correct. And this wasn't intended to do a 90 and a 90 because you already took care of it with may versus shall. I believe that section was, let's say my CRA has provided me 100 actual clients that are currently in the recovery residence. That CRA gets terminated or quits for any reason. This was to just give a further guidance to remove a regulatory framework which could potentially force somebody to shut down 50 of your 100 residents and tell them they have to go on the street if they can't find another place. So you are correct. There should be 90, and May does handle it. I believe that extra paragraph was being extra cautious. And I think that if it's removed and everybody is fine with FAR being the determinant for it, I don't think anyone would have a problem. But it was meant mostly to be extraordinarily cautious to make sure that an individual's life wouldn't have to be put in jeopardy by having someone come along and say, now that 50 extra beds you have, now these people have to be thrown on the street. And so
Right.
I think everybody agrees with you in what you're saying. This was just an extra level of precaution, but I think that the rest of that works if everybody's in agreement.
Okay, thank you, Tori. Two other hands were raised, whose hands were raised?
It's on there, Kelly.
Oh, comments.
Come on.
Oh, there are a lot of comments.
No, go up.
Oh, go up.
No, this way.
You take care of it.
Here.
I have
Here.
my AI here.
There you go. Kelly.
Okay, yeah, Kelly, did you want to comment?
Unmute. Sorry about that.
I'm sorry, Lee.
Unmute.
Yeah.
Thank you. I was just in listening to all of this, the comment that I have is that if in that paragraph that you just add just a little phrase that says without impacting the current level of residence, that B, if you just added that could kind of incorporate what was trying to be solved in C. Does that make sense?
I don't know. Are you talking about in B?
In B, yeah. So because it's gone from the 90 days and that may revoke the certificate of compliance of any recovery residence that fails to comply with this paragraph. And then where was it that I was thinking this? But how the recovery residence has 90 days. And the whole examples were talking about how the CRA had 100 people, and then that person's gone. And then so you have 90 days to replace this person, but you can only replace it with someone that is certified for 100 and not 50. So that during this time frame, that when that person is terminated or however they resign and they leave, that they have 90 days to put someone else in place, and that the current level of residence is not impacted by this quandary of the CRA being terminated.
Okay.
Does that make better sense?
Yeah, that does. Let me hear from Josh with FAR,
Yeah.
Director of Certification. What did you want to say, Josh?
Yeah, thanks, Al. So as far as this goes, so as Director of Certification, a CRA is removed for whatever reason. A provider contacts me, say this is going to be our CRA of record. I would immediately say, you have up to 50 beds and this is a 75 bed program. We have to develop your CRA coverage policy. And that's something that we could start working on then. And that shouldn't take too long. I would help get them in compliance with that CRA coverage policy. And I think the May revoke will allow us to have a few weeks to be able to develop that, so they're not losing any beds. So that's something I would never do. I would never say you got to get rid of 50 of your beds right now,
so
until you get this coverage policy.
So what you're saying, Josh, is from the FAR perspective is, you got the provider has 90 days. So nobody's getting thrown out on the street. They got 90 days. At the 90th day, if in the 89th day, they finally find an employee to replace the existing employee, you're saying by putting May in there, that it gives FAR the flexibility to spend the week or 10 days or whatever it takes FAR to okay the beds from 50 to 100. I mean, the whole,
Yes.
you know, I mean, nobody wants to see 50 or 70 or 25 or 50 people, you know, out on the street because, you know, all of a sudden the place is not certified. I've never seen FAR take an action like that. Okay, all right. Let me think about whether we can add a sentence that, that it's hard to do in legislation to say what, you know, of paramount importance, for example, is the stability of the residents in the recovery residence, which is what we're talking about. But I think we're good. I think we're good either way. I'm gonna think about also what Uta said about, and that's part of it. You know, you don't want to impact the current level of residents. Okay, so if we can come up with something, Uta, if you come up with some language, just send it to me. You know, the bill's not been filed. I've got to get it. I do have to get it out to our delegation here in Palm Beach County in the beginning of next week. But let's move on.
Oh, hey, Al, I'm sorry. Dr. Needle was wanting to raise her hand. and say
Oh, I'm
something.
sorry. Dr. Needle.
Thank you.
Okay.
Thanks for reading my hand, Becky. Hi. So two things real quick. One, I wonder if we would all feel this would be more comfortable in putting some sort of time frame if there was some sort of contingency where in general it was required that not only was there a recovery residence administrator, which as I voiced before, it doesn't actually always do that job, but there was like somebody who was like a second that also took care of, was part of the process, so that if one left, the other was able to, even if they weren't certified as one, was able to at least make sure that the residents are taken care of and that there's consistency if our concern is for their well-being. And then maybe that number would feel a little bit more comfortable if we knew that there was that contingency plan anyway, like that was part of what was required. Second thing I wanted to mention was about the number, and that was always sort of a difficult one for me, not just for this, but when we talk about medical director, clinical directors. And I think that rather than a subjective number, as Jeff mentioned, like that something, rather than a subjective number, it would be, I think, more comfortable to have something in place that talked about what the roles and responsibilities are and how we make sure that that is maintained. Because as it stands right now, in all of the areas that we have this number subjectively put on, again, the other, you know, it's not just with recovery residence administrators, how many patients they can be oversee, it doesn't always happen that that's the case, that they're actually overseeing the care. So I prefer some standards in place for how we can make sure that those things are happening. And then I'd feel more comfortable if those things could actually happen with having an increased number. And I don't know how others feel about that, but I just wanted to mention that.
Well, a lot of this is talking about level 4. And again, I'm gonna reach out to the wisdom of Uta when she says the more you put into legislation, the more perilous it can be. And again, I'm paraphrasing. This is what you're thinking about is much better said in policies and procedures or rules when it comes to the department than it is actually specifically writing into law those kind of ratios, because there's always going to be vagaries. There's always going to be, okay, at what point do you draw the line? What number? And we actually are doing that in the next, either the next one or the one after. We actually have patient to clinical personnel, and we also have resident to employee for the residents. So we can kind of get there, but we can't get into the weeds with this. The process doesn't allow for it in legislation. It's going to be so convoluted. So we do rely on DCF for their rulemaking to carry out the actual meat and potatoes as it is, and also FAR, or the certifying entity, to do the same with regard to recovery residences. But thanks to Susan. You're the last one for now. Anybody who has any additional questions or suggestions, feel free to send them to me. Again, the statute is written and approved by Dave Ehrenberg, well, by me and Dave Ehrenberg. But we welcome any of your suggestions and input. Susan?
I would just add, less is more. I agree with that. So in terms of making this simpler, it really is important. In terms of Rachel's point, it is something that FAR is doing in terms of fine tuning as best we can all of the policies and procedures for a recovery residence in, what are they supposed to do for this, and the other thing? Because that is, I agree, Al, that's where it needs to be, because that is much more adaptable to some unforeseen events or things that happen out there. So we can go back and amend that a lot quicker than we can do this. And, the simpler the statutes are, the more the more easily they are enforced.
I mean, we could do something like 80 days to retain a certified recovery residence administrator, and then the certifying entity has 10 days to approve any certified recovery administrator that to manage more than 50 residents. I mean, we could do that, but I don't think, I just don't see it's necessary, because
Yeah.
FAR's got the May.
Right.
That's why May is in there. So if you're close, you don't upset the recovery path of 50 or 100 people, just because you got 2 days overlap or something. So
And the second point that Rachel is making is what, in that 90-day period, what's going on, right? I mean, who is overseeing the residents and doing that stuff? Well, that does fall to the operator to work that out. I mean, at the same time, they can have their time to get the proper personnel, but it doesn't mean we don't have to do anything. And that's the other thing that FAR is involved with. So I think that solves that issue. And of course, more will be revealed as we go.
well, correct me if I'm wrong, but the levels of care, level 3 and 4, there has to be staff on site.
Right.
You're talking about house managers. You're not talking about CRRA.
Right.
CRRA is an administrator that administrates over however many residents. It's not, I know people get confused about the difference between a house manager and a CRRA. So, there should be oversight. If it's 24/7 oversight, it's 24/7 oversight, whether you have a
Agreed.
CRRA or not.
Right. Whether we have CRRA or not. Exactly. That is the point. I agree
this will be-
100%.
And some of this will be answered in the next statute that we discuss. Okay, moving on, because we need to, okay, taking a little longer than I thought it would. But anyway, D, which would become C again. It came to my attention that 435.042, which talks about the qualifications on a level 2 background check, and et cetera, et cetera. We're just amending this section to comport with the language there, which is not only is arrested or found guilty of or enters a plea, but it actually states in 435, arrested and awaiting final disposition of or found guilty of. So this really is a ministerial catch up with another related part of Florida statutes. So, okay, let's move on to 5. Five is a real barn burner. Because 5 now, and it's really timely that SAMHSA came up with their best practices at the same time, because my initial reaction to 5, okay, which is basically saying MAT is required. All right. And now I don't know, what's the number estimated, but 40% of certified recovery residence beds accept MAT? We got a lot of educating to do. My fear was that doing this would cause a number of recovery residences to drop their certification. And I'm talking about the level 1s and 2s that are not engaged in the higher levels of care. But anyway, I'm just throwing that out there. But here we go with 13. Recovery, this is major stuff. Recovery residences may not deny an individual access to housing who has been prescribed federally approved medications that assist with treatment for substance use disorders by a licensed physician or an advanced practice a registered nurse registered under appropriate statutes solely on that basis. And actually I misspoke, because this is all recovery residences, not just certified recovery residences. So there's no impetus to quit FAR. Okay. Hands? Dr. Schlosser, I promised you that we'd come back to you. Is this okay in terms of what you were talking about earlier?
Yeah, I think it is. My concern is just that we don't want to mention just 3 medications.
Well, we're not mentioning 3 medications. It's all any federally approved medication that assists with treatment for substance use disorder.
Right. And I guess I just want to clarify that from the legalese. Do we have to say all substance use disorders? Because we have, opioid use disorder, alcohol use disorder, amphetamine use disorder.
If a house is accepting, my read is if a house is accepting a person that has an opioid use disorder, for example, and they have other people in the house that have alcohol use disorder or benzodiazepines or cocaine, but that person that's admitted into the house, that is allowed to come into the house, can't be rejected solely on the basis of the fact that he has been prescribed or she has been prescribed buprenorphine by a licensed physician. So yeah, the same thing with alcohol. I mean, there are drugs for alcohol withdrawal as well, but that's usually for withdrawal, not long-term. But anyway, I saw Dr. Simonides, you had your hand up as well.
Yes. Yeah, thank you. Yeah, just I want to clarify this, because now that's, it's really burdens a house with the responsibility of dispensing or administering medications. And is that true only for substance use disorder medication or any kind of medication? I mean, for heart medications, for lung medications, for diabetes, insulin. Do we really want not to allow a house with certain limitations to be able to function without if you don't have available medications or the capacity of dispensing medications, you cannot operate?
Well, that's a good question. I'm going to start and then ask for FAR's input. Number one, it's not rocket science to have a lockbox with medication in it. I do believe that diabetes medication is different, or heart medication is different from a federally approved medication for SUD or OUD. I know there are policies as to exactly how that's done with the medications, MAT, medication-assisted treatment forms of medication. It's not difficult, but there should be a house manager that can dispense the medication, or at least open up the lockbox and allow the resident to take the prescribed dosage. Can I hear somebody from FAR to chime in on this? Because that is a good question for level 1s and 2s.
Let me do it,
And I
Al.
know that Oxford House, just say one thing, because we talked about it in the last meeting, Oxford House, in order to have a charter, you have to agree to take MAT. So, okay, that's level 1, pure and simple. And it's not a difficult task. But anyway, I see, can I hear something from FAR and then Uta after that?
Yeah, let me, Al. So a couple of things that about these points. Number one, the issue, recovery residents were taking individuals who were being prescribed medications for their heart disease, diabetes, or any medical condition. The stopper was MAT. And why is that? That had to do with, the understanding or misunderstanding of the recovery residents operators about what MAT is and isn't. So, but the bottom line still remains that if it is appropriately prescribed by, a federally approved medications, right? The problem wasn't with the other medications. The problem was only with this. But this applies to all medications. The point is the recovery resident operators are not medical doctors, right? They're not physicians, and they're not in the business of monitoring the medications that are prescribed. They are responsible, however, and there are FAR guidelines and help to how to properly, manage individuals who are on any medication, but particularly MAT, because MAT is being misused, has some problems with it. So they're not dispensing because that would be illegal, right? Dispensing can only be done through a pharmacy or a hospital or something like that. What they are simply doing is making like lock boxes safety for the individuals. So, it's not burdensome to do what needs to be done here if they do it properly. They will get help from FAR. If like, hey, I don't really know how to do this, we have policies, we have ways to show people how to do this safely and efficiently. And if you look at level 1s, and Oxford House as an example, those folks keep their own medicine, right? So, do you want to do that? You don't want to do that, depending on your population, right? But, Oxford houses are not FAR certified. So they do it a different way. But when we talk about this is intended to make it clear that it is discriminatory to say to somebody, if you are on any prescribed medication for your substance use disorder, you can't live here. And there are a number of places like that. So FAR's objective in the next year is to do as many trainings. And, I've talked to members on this panel about talking to folks about getting them in here, right? But that's the point. So the risk of denying those people is far greater than incorporating that, because that's what we are. That's the state of medicine today.
Okay.
So that is FAR's position. That is what FAR is doing in terms of and how are we rolling this out? We talked about this too, right? It's not going to be like, if you don't do it today, we're going to start educating the providers as they come up for renewal and as we go, because this is the objective.
Perhaps we should put in 13, before I get to Uta, that we should have this take effect.
Right.
January session would take effect in July, and maybe
Yes.
we should push it off till January 2025.
Right, or July of
This section shall
2024.
take effect
Yes,
July
I agree. That would
2025 or
be,
something.
I think that's a necessary
Or
addition.
January, okay. Uta, you had.
Yeah, I just wanted to just echo what Susan said about, I think we need to keep in mind and I'm seeing also the comments on the side. This is a recovery residence. People live independently. Just like somebody who is on medications at home manages their own medications, people in recovery homes manage their own medications. So I think we need to get away from words like dispensing, monitoring, because those do have legal definitions. And that's not what happens. They're in a lockbox, so nobody else can get into them. And a lot of people have even lockboxes at home so that they're not, and they're actually controlled by the prescribers and by the treatment provider, because to not, allow them to take more than their daily doses. But I think in terms of this language, I would just throw out there as a suggestion to, number one, talk about controlled substances, not all medications, because like, the doc brought up earlier, does this include diabetes medication? It probably, doesn't. So controlled substances, as well as, do we really want to limit this to substance use disorders? Because I'm sure you have a lot of co-occurring folks in recovery residences. And if somebody has something for their mental health, so again, I would be more inclined to say, controlled substances, leave out what it's prescribed for, right? I mean, to me, that's irrelevant, but just say, that you have to, accept folks, you have to, be able to be open to folks, and then, controlled substances can be managed in lock boxes and so forth. That's just my thought.
Okay, well, I think this doesn't talk about lock boxes, and now that I realize that level one's Oxford House, they allow the residents to handle their own medication, which, is appropriate in the level 1 and 2. That's basically post-treatment. Yeah, I don't know that we should limit it, because can you tell somebody they can't live in your house because they are taking diabetes medication? I don't know. But we could say has been prescribed federally approved medications that are controlled substances that assist with treatment for substance use disorders. Because actually, that will assist with treatment for substance use disorders kind of leaves out the garden variety. I've got diabetes, or I've got heart condition. Okay, all right. Let's see. We have 4 other hands raised. Okay, don't want to take too much time on this, but let's see. Mike Schlossman, go ahead. Unmute yourself, sir.
Thanks, Al. I was giving you a thumbs up. I wasn't waving my hand, but but I think the distinction and where this came from was that one is a protected class and one is not. In practice, I don't think that a recovery residence would discriminate against people with diabetes, whereas they might discriminate against somebody who's on a federally approved MAT regimen. And under that, they are a protected class. But just as some background, I know we've talked about this a million times, is
1959.
Based on our research, this is a recitation of what already exists in federal law. There's case law after case law.
Oh, you
muted the wrong one.
That's okay.
Sorry,
There's
Michael, step back on that a little bit, because we're trying to mute somebody else's over talking. But go ahead, your last sentence or two.
Sure. So this is a sort of a recitation of what already exists in federal law, mostly in case law, grounded in the FHA and the ADA. And this goes back to cases of, I believe the first case that I ever read about was a nursing home in New Hampshire or Massachusetts that denied application of an elderly resident who was on buprenorphine. And the reasoning that the nursing home gave was that they're not equipped to do it, they're not trained to do it, they don't know how to do this. And essentially the settlement with the federal government was, that's not a valid excuse. This is a protected class and you have to get the training, you have to get the expertise, and you have to do this. So I just want to make a distinction between a protected class and a non-protected class, and be careful that we're not overreaching here.
Okay, thank you, Michael. Tori.
Yes, thank you. So Susan and Michael both took some of my commentary out, so thank you guys, and I agree. But I think it's important to fall on what Michael just said. Um, I think some education might be in order also for individuals to study up on what CRA is and what's going on in a level 1 Oxford House level 2, 3, and 4, because one of the reasons with especially what you would call a much more active FAR with really, really good forward momentum of its board members and of its active members is to try to right some things that were not correct. And so this really doesn't need to be updated for anything. And I think as far as the language, what I mean, it's good language and it covers, as Michael said, protected versus unprotected. And this is also part and parcel of the definitions between 1, 2, 3, and 4. Because if you're a part of a level 2, and Susan pointed this out, look, you're not dispensing, you're observing the medication. You're not, and you don't even have to go as far as observing it in a level 2 scenario, but you're not dispensing. In a level 4, because of the interconnected nature of the therapeutic housing model with the clinical model at a clinical building, which is part of the licensed service provider, your medical personnel will be the prescribing doctors generally for most of the medications they're on when it comes to this type of class of a substance use disorder. So we're actually directly targeting the requirement of what is needed. We're not trying to target something that is not needed within this. And so this has been vetted very, very heavily by the provider class as well, which goes through this on a day-to-day basis. And so that's why this exists in this offering in this statute.
Okay, thank you, Tori. Let's see, I think Heidi, did you have your hand up?
I did. I just have a real quick comment. I think if we use the terminology, I think language is very important. And using controlled substance, we have to be very specific that it's for medically assisted recovery or medically assisted treatment, because controlled substance could open us up to a lot of opportunity for different classes of medication. That's all. It was my only comment.
Thank you. And Will, you had your hand up. Last comment?
Yes, sir. And I apologize. I'm approaching this from somewhat of a opposite angle, and just hope that the community can hear this. We have these communities with the family dynamic of a singleness of purpose, and as much an importance it is as it is to have housing and appropriate levels of support for people on controlled substances like MAT, etc. I've provided MAT housing throughout my time in sober living application, and I see a value to this in level 3 and above with staff on site. And I also see the importance of a democratically run home of being able to manage this process. I think it gets really interesting when we do have managing meds that have been used as economics within those homes, where people who are prescribed MAT give them to people who aren't prescribed MAT. I don't believe there are enough protections in place for abstinence-based pathways alongside MAT pathways. So as much as we're doing everything we can to make sure that MAT isn't discriminated against, we are inadvertently creating a system that almost eliminates abstinence-based environments in Florida. And I'm just concerned, having had experience with this, that we don't seem to be taking that into account at all, or providing any type of protections for what would be considered traditional sober living homes that don't have whatever is going to be called a recovery pathway next, like maybe benzos for anxiety disorders, or if we get around to describing marijuana or kratom as a harm reduction process for opioid use disorder. I really feel that it's counterintuitive to what we want for recovery residences, if we can't provide that type of protection for an abstinence-based process. Everything is absolutely correct within the law, but I feel like this creates a brand new problem.
And I hear you. I've talked to many people who are abstinence-based, and it is not uncommon, although it's being more and more accepted. Now, when you talk about kratom and marijuana, those are not federally approved drugs. So they are not in this. Now, benzodiazepines are FDA approved. And if somebody has a prescription for anxiety for Xanax, you know, I see your concern. Now, each of these houses has the ability to expel somebody for you know, for actively using or certainly for selling their prescribed medication or giving it away. Okay, I said last word with you, but I'm going to allow Tori the last word. Go ahead.
So to that point, this is why we didn't get further into the weeds, and it says assist with treatment for substance use disorders, right? It's specifically in regards to things that are adding to the benefit of the recovery community, which generally focuses on things that are standard applicable practices within SUD, rather than SUD and then including the other monikers that follow after it with different levels of primary mental, co-occurring and so forth. It's because the recovery community were being very friendly to it to try to come into an understanding and a balance, a delicate one at that, with what you just heard before I spoke with the gentleman who just spoke. This is where we cut into this and said, where can we go where we're not treading on, but we're including and helping? And that's why this language, as I said, was put through the ringer for a period of time with people who had their input that do this every day. So that was what this was for.
Well, Tori, and I appreciate that. And I think that's the majority consensus. But to give Will some due deference, what strikes me and makes me a little fearful, it's still a best practice. So, you know, sometimes you gotta jump. You gotta jump because it's the way to go. But I do see this being abused. Hopefully it'll be anecdotal, but people who have in the lower levels of care where it's not controlled by clinicians, people will have their subscription to buprenorphine, for example, and they can give or sell or trade or barter their medication. And that's, I think, one of the concerns. It's still not an overriding concern because we have to look at the large majority of people that this will be beneficial for. And I think that there's education to do, and giving the process a little more time for that education to happen, I think will be great. I think that Dr. Schlosser, you had your hand up really briefly because we have to move on.
Yeah, I was just going to say what you just said, Al. It's about education. People who are using medication can live alongside people who aren't using medication. It's just a matter of educating everyone on the benefits and the data to support using medications, if that's what someone needs.
Thank you. Okay, 14 is really just conforming to the fact that duration or frequency of residence shouldn't be a factor when you talk about local law and ordinances, regulations. This came out of a number of incidents where, and it's been happening for years, where local government, when the attorneys are not really educated, I'll say that, on the ADA and the FHA, are looking at trying to regulate by over-regulation and calling, and I know, Terrell, you've had you've seen this, calling recovery residences board and care, I think is the term, or, you know, looking at them as Airbnbs or hotels or whatever. And this basically says now that the length, duration, or frequency of residence is not, that can't be regulated. That violates federal law. So unless there's anybody who, Terrell, you have your hand up, go ahead.
Thank you, Al. I just want to point out that while I do agree there is a need to clarify this, my concern is that the way it's written, it could include single-family zoning districts where multifamily is possibly a non-conforming use, especially in older communities. My suggestion is to change it instead of saying certified recovery residents in zoning districts where multifamily uses are allowed, to say in multifamily zoning districts.
Okay. I think that's reasonable. Tori, you want to comment?
Yeah, but the zoning district issue is being used as a cudgel as well. And what they're doing is they're taking communities which have a significant presence of multifamily originally constructed domiciles, and they're then retitling something as a single family use district rather than leaving it what it was before and saying that just because it's non-conforming doesn't count any longer for our purposes of what this industry does alone, meaning it's highly discriminatory and it's selective just towards our industry. Because if I were to purchase as a regular landlord, right, a landowner, and I purchase a 12-unit multifamily structure on a single folio, and I decide to rent it out to a specific amount of individuals that fall within those zoning codes and regulations, I'm not necessarily individually discriminated against regarding that zoning district because it's still a non-conforming use of the multifamily process. So what that would do is saying, hey, by according to a multifamily zoning district, you're basically giving cities carte blanche to say, we're going to just rename everything single family here or there, regardless of the original intent of the structure's existence. That's why this language is selected specifically.
Let me ask this question. Does this practice, or would that practice violate federal law? In other words, right now it's my understanding that it's in violation of federal law, the ADA and the Fair Housing Act amendment. Why don't you comment on that, please?
Sorry, what did you say?
Oh, Terrell, go ahead.
Okay. I don't know that it's not necessarily in violation of federal law, because it is expected that, well, let's back up. It is expected that multifamily is going to turn over more frequently. Again, and that would be somewhat, I guess the language in that regard is consistent with federal law. My concern is that to the extent that it provides for it to occur in zoning districts where multifamily uses are allowed, it opens it up to single family homes in zoning districts where multifamily uses are allowed. And nobody expects single family homes to turn over so frequently. And just as cities and counties have tried to fight against vacation rentals, this would be the same argument just as it relates to the turnover, the frequency with which the properties would turn over.
Okay. Do you think, Carl, that, well, I mean, we could put this language in and see how it flies. But do you think that this would be a poison pill for the League of Cities and the Association of Counties?
I'm not speaking on their behalf.
No, you're not. I'm just asking. I'm asking you.
But just based on years of presenting to them on other issues that we have had, for example, fire safety code issues and building code issues in this space, I have heard them talk about, and being a city attorney, I have heard them talk about their legislative priority basically being to try to stop the state from preempting cities and counties from regulating vacation rentals. So that is a top priority for them, and they're going to view this in the same way just because it has to do with the frequency with which the properties turn over. It has nothing to do with who's living in them. Again, I think if it was more clear that we're talking about multifamily zoning districts, there would be less of an issue. But to the extent that it could possibly capture single family homes just because a multifamily use is allowed there, it seems to be a concern.
Okay.
Hey, Al, this is Tom Baird.
Oh, I'm sorry, Jeff.
No, Tom Baird.
Yeah.
Oh, yeah, Tom. Go ahead, Tom.
I want to echo what Terrell's saying. I think and I can only speak for 3 municipalities, but I think that the view of this would be another partial preemption of home rule authority. cities have seen the legislature chip away at it for years now, and they're very sensitive to restrictions on one of their most sacred police powers, which is zoning. So I think that I don't think that it would be well received at the League of Cities.
Okay. All right, Jeff, oh no, you took your hand down.
Yeah, I mean, I want to,
Okay.
Carol's concern was that the way it's drafted, anywhere where a multifamily use is allowed, you could do this, which means if you have a single family district where multifamily is allowed, you could use the single family structure. So let's just fix this language to say, a local law, ordinance, or regulation may not regulate the duration or frequency of resident stay in a certified recovery residence in a multifamily structure in zoning districts where multifamily uses are allowed. That resolves the issue, as opposed to the League of Cities and their concern. You know, let me just rant for a second that, you know, we didn't create the American with Disabilities Act in 1990 because all of a sudden we found God and enlightened thinking. We didn't pass the Fair Housing Act because all of a sudden we thought it was just good policy. We didn't adopt the Civil Rights Act because we thought, yeah, it's been 100-something years, let's get it done. No, it's because cities were the ones to discriminate against certain populations in their zoning and in their things. And so it took a law 33 years ago to say no longer. So the fact that we're trying to balance discriminatory zoning with, you know, whether intended or not, with what the cities want. I mean, this is the State Attorney's Addiction and Recovery Task Force. I think we err on the side of doing what's best for the entire recovery, you know, community, which is to stop having cities use their turnover requirements as a cudgel to say sober living, you're not allowed here. It's, you know, you're right. The state did it for Airbnbs. I don't agree with that. Do I think the state needs to do it for recovery residences? I do. And so, you know, at what point do we stop placating cities who are, you know, and I respect the heck out of Terrell and Tom to death. They know that. This isn't about them. This is about NIMBYism and that people just don't want recovery residences no matter what they say. And so there's a higher state policy, and that policy is we're not going to let you use your zoning power through a backdoor way of transient use to prevent what is absolutely necessary housing, at least, and we're limiting it to multifamily, and let's limit it to multifamily structures. But really, that should be it.
All right, Jeff,
in my opinion.
Well, I will make one comment. Perfection is the enemy of the good. You know, I could agree with you 100%. And then I know if we put a pill into the bill, it won't pass. John Hewlick, then Tory, and then we'll move on.
Hey, Al, thanks a bunch. This isn't a substantive item. I just wanted to weigh in and let you all know that the board yesterday approved an extension of its contract with FAR through September 30th, 2025. So we've got a couple years worth. The aim of that is really twofold. One is definitely around the concern and issue of expanding MAT capacity in Palm Beach County. Along with that, there was tied a lot of educational deliverables with respect to that. So the costs that might be borne with respect to that are part and parcel of this contract. And the second element of that contract, Al, is the integration more robustly of Recovery Capital Index within the sober home environment. So the county via that contract is certainly weighed in on this matter in support.
Okay. Thank you. Thank you, John. Tory, go ahead.
Well, yeah, and I'll echo, you know, here's the thing. We are not, as a recovery operators, recovery residents, you know, level 4s and so forth, attempting to be at crosshairs with cities. And I think we have to all take into account what did happen before now, what is happening now, and what needs to happen in the future. And a lot of people, I think, are passing or wanting to hold on to specific abilities to pass certain laws, which they might think will be altruistic so that they can help better integrate recovery residences into their counties and cities. But that's not how these rules are being viewed. And I think when you ask the question, Al, do we know what or what does not violate ADA and FHA? I think it comes down to the fact that a lot of recovery community operators, right, level 4s or detoxes, people who have money in this industry, just haven't sued anyone yet. And I think when you see those lawsuits go through, which is what people will be pushed to do, that it comes to a different element where nobody wants to go, which is why this negotiation and this dance where everybody's trying to respect each other, myself included, with what cities and municipalities and their citizens are looking at with education. And so I think the problem really comes down to, and to Terrell's point, a lot of people aren't going to fight her or what Mr. Baird was saying on single family issues. I think the concern really, really comes down to the multifamily situation. And if I may be so mannerless, is to say that if I were to purchase, let's say, a $1.4 million single family home 2 houses down from a multifamily folio, I don't think I necessarily was expecting the same rights of zoning regulatory structure as an individual who goes into an HOA or into a gated community of all single family homes. And so we're going to have to figure out, as Jeff was pointing out regarding original structure or multifamily structure, how we do this. Because on the one hand, none of us are trying to create an environment where you're going to have HOAs overrun in single family homes with individuals just popping up all over the place. The other side of this, those laws that we are watching being passed in some cases weekly right now that really probably don't hug to the law as far as the ADA and FHA, you're going to not have treatment left because you're not going to have recovery residences. And so there's got to be a better balance than one side saying X and one side saying Y. So I'm happy to talk to Terrell and you and everybody else about this language, but this multifamily issue is a very big deal. And it's an incredibly intricate aspect of recovery residences within treatment, as is, proper regulation of single family. And that's why FAR's here, right? To not let things get out of control. And so there's got to be some deference put aside to FAR as well and what they do and how this is being integrated. And I think we're going to have to figure this out because that language is highly important to the providers of this industry.
Before I get to Terrell, I just want to ask Jeff a question because you're on the front line, you're in the trench on this. I get what your fear is. In other words, that by saying multifamily zoning districts instead of uses are allowed, that you are afraid that that communities will pretty much blatantly, take multifamily districts and change them to single family, even though the homes in the district are multifamily or the majority are. How many times has that happened? Where
what I've seen, and it's happening right now with the Live Local Act, is what I am concerned with is not that they're going to rename it single family, is that the way it's written right now, it says multifamily zoning districts, non-defined term, right? So you have cities that, you can't change your zoning map and you cannot change the list of permitted or prohibited uses in a zoning code without having multiple hearings. It's actually governed by statute in Chapter 163. You need to have all these procedures, you have all of these hearings. That's just the change, again, the zoning map or the list of permitted uses in the zoning code. What I'm concerned is going to happen is a city's going to say, okay, again, League of Cities, here's Morse code. You may want to look at your zoning code, and if you don't want this to apply to you, then rename some of your zoning districts. Just remove the word multifamily from it.
Right.
Just don't call it multifamily. Just call it something else. You don't have to call it single family. Just call it something else. That doesn't require 5 hearings. That doesn't require public hearing. That's not even a zoning text amendment. I mean, I guess it is, but it's not changing the list of permitted uses. It's just changing names. No one would notice. Do I think it's going to happen? I think cities are already doing it with the Live Local Act, which is the law that was passed by the legislature last year, which says if you have any property that's commercially zoned, any developer can develop multifamily on that kind of property. So cities are now changing the names of their zoning districts, some of them to deal with that forced reality on them. So the answer is, I'm not going to wait for that to happen. And yes, I see it happen. And I'm not going to wait for this to happen here, which is why we're recommending we try to find some agreeable language.
Well, we may be in a position of, I know you're anticipating something, but it hasn't happened. The legislature meets every year. So if all of a sudden it starts happening, if we say zoning districts, and all of a sudden we see this happening around the state, the legislature will be meeting 8, 7, 6, or 5 months in the future, and we can go back. I'm just saying, it hasn't been happening. You have experience to think that it will. My fear, and I'll let Terrell have the last word, but my fear is that you take Wellington, for example. You may have a block of duplexes, okay, and it's surrounded by single-family residences for a mile in each direction. Now, I'm not so sure that there's there's a multifamily district use in that one place, but I know darn well that if all of a sudden somebody uses that where multifamily structures are allowed or unit uses are allowed, then all of a sudden the rest of the entire district is open up to recovery residences as a permitted use. And my understanding is there are restrictions. So I'm not artfully saying this, but I think that the opposite may happen, and that Tori mentions that the concept is not to open up multiple recovery residences in single family units. But I think the opposite is going to happen, that there will be if the language is too porous. That's my concern, Terrell. And again, I'm a half a loaf guy. You all know that. Sometimes it's a slice of bread because we're still moving forward. And if it's abused, we can come back and we can attack it again. Terrell, your last word.
I was just going to say, in the alternative, I know we're doing the statewide study. I don't know if it's something that could be addressed through next year's legislation. And perhaps in the meanwhile, we could do a massive education campaign, because I feel like that really is needed on all levels. I understand Jeff's concerns and Tori's concerns. I've seen them. I've heard the stories as it relates to some municipalities and how they treat essentially recovery residences that are in multifamily zoning districts or multifamily structures, as they phrased it. Again, my concern is just that if the language is too broad, it opens the door to the frequency of turnover in single family homes. And I don't think that would be supported by cities or counties based on, again, just treatment of them by the state as it relates to vacation rentals. So I think massive education campaign, maybe address it next year. Those are my thoughts. Otherwise, if we're going forward with it this year, I would suggest changing it to multifamily zoning districts. And as you stated, maybe there would be a glitch bill next year if it turns out to be a problem.
Right. Well, right now there's nothing. So better to have multifamily zoning districts than nothing this year. So let's move on to the Recovery Residence Administrator, number 6. This is kind of narrowly tailored, just to open it up. This really deals with, and I've been educated on this, deals with level 4s. These are your day-night with housing or IOPs, where we're talking about this this more robust system where providers own their houses, and there is going to be more of a demand for certified residence recovery administrators in a larger capacity. So the one thing that I've always been worried about, and I'll say this, I've said it to a number of you privately. There was a place in Boynton Beach that basically was a takeover of a Century Village type blockhouse, 4-story, 3-unit apartment building. I don't know, probably 200, 250 residents, maybe more. It was barbed wired, it was fenced, there was a guard at night. We did a ride through with fire rescue. This is in 2017. I've never seen a bunch of more depressed young adults in my life. Drinking Red Bull, drinking coffee, smoking cigarettes, loitering outside the residences. And everyone that we asked was from another state. I understand that's been, well, I know that's been cleaned up because that was the result of patient brokering, I believe. They were not prosecuted, but in hindsight, it's one of the cases we should have taken. But the object here was always what's bothered the legislative sponsors when we tried this last year was having a CRRA, and last year it was 250. I think this year we've amended that. But the concept of even an administrator having that much to administer and to have that much of a concentration is going to draw some opposition. With that said, I think this can pass. I think it's good. I think it's specific. There aren't going to be many in the state of Florida that this applies to. If you look down here, it's no longer 250 residents, it's 150. So it's an increase of 50 to what's already approved. That's number one. The patient ratio, if you look to line 23 and 24 and 25, the patient the personnel patient ratio is 1:8. And there's a 24/7 on-site supervision at the residences with a personnel to resident ratio. Now I put down 1:8 here because I'm thinking of an ordinary recovery residence. It could be 1:10, that would be sufficient. Dr. Moran sent an email saying that there are hours during the day when somebody is at work, for example. I don't know if they'll be at work at a level 4, but or somebody's they're certainly clinical for 5 hours a day, 5 days a week. Or if it's IOP, they could be at work because it's 3 hours, 3 days a week. The idea of 24/7 on-site supervision with a personnel to resident ratio of 1:8 is not to have somebody with eyeballs on people. I mean, this is a realistic type of situation. This is monitored by FAR. We're really talking about when people are in the residences that there's somebody that has an eyeball. We're not going to see people, buy drugs on the street, come back to the residence and OD in their room with nobody there. Dr. Moran recommended a 1:25. That's almost like a recovery residence administrator, which is really an administrator. That's not eyeballs on. And it's mostly when people are sleeping and they get back to the residence. But if this is a level 4, there's going to be hands-on. So there's going to be 24/7 because they're going to be at treatment for the time they're not at the residence. And if they go somewhere else, okay, but there'll be somebody for them when they get back. I'm just kind of saying in general terms of 10,000 foot, I'm certainly not opposed, and Dave Ehrenberg is not opposed to this expansion. I talked to Neil McGarry about this. He was a little bit concerned with 250, but I think he's not in the meeting here, but I'll be talking to him. I think he'll be okay with 150. But let's is everybody okay with this, first of all? And number two, 150 and 1:8, not only clinically, but in the residence as well when people are in the residence. What say you? Hands? There's one more change that I wanted to make, and I'll get to you, Tori, in a second. On line 28, it says, well, actually leading up to it, that sentence, certified recovery residence administrator who has been removed by a recovery residence due to termination, resignation, et cetera, shall not be allowed to continue to actively manage more than 100 residents or another service provider without being approved. I think it should be 50, because if they leave, you go back to square one, and then and then FAR should have to approve them for 100 or 150.
Now I'm going to interrupt for a second. It's Jeff, that's the intention. So rewrite that. That was what that was meant to say.
Okay, so let's go back to 50 on this, and then
You should say you don't get the benefit anymore
Right.
of above 50. So that's what that was meant to
You can't jump ship to go to another provider and leave your
Right.
provider in the
Right.
list. Okay.
Right.
Without-
And you don't get the benefit of that because the approval was tied to the provider.
Well, you actually can. It's just going to take a few days to get recertified.
No, right.
Or approved.
That was, we're all on the same page. Yeah.
Okay. All right, Tori, you have your hand raised. What's up?
So the standard right now to get to 100 is 1 to 12 at housing. That's already in the rules. So the original intent of this was 1 to 8 as an entirety of your program, because this generally is for a level 4 program, right? So you're talking full competent level of staff across the board. I believe you added 1 to 8 clinical and 1 to 8 on site. 1 to 10, clinical, 1 to 8 on site is fine. The on-site supervision part, Dr. Moran is correct that you will have your tech staff, right? Your behavioral tech staff, because, and I think it's also important to mention, the CRA is a Florida requirement. It's not a NAR requirement, and it doesn't work that way in any other state. So what we're doing with the CRA here is we're creating a new class of individual that, and I believe Susan brought this up a while ago in our conversation, that a proper run facility at this size and this intention is going to have a lot of other staff if they're doing it right. So the CRA is an administrator. The 1 to 8 ratio is talking about a behavioral health tech staff, which means for every 8 residents on your property within the recovery residence, you will have to have 1 staff member called a BHT for every 8 residences. The reason the 1 to 10 works is because the 1 to 12 is the current standard. So you have 1 to 8 clinical, which means all people included, and then you would have 1 to 8 or 1 to 10 at residence. So I think the biggest problem with this is going to be when you say on-site supervision consistently, because those personnel might be with the other individuals. And I know this isn't going to always sound like what everybody wants to hear. What you mentioned is an unfortunate reality for both good and bad programs. And I'm happy to let anybody else from FAR and everyone to comment on this, but because no one is mandated as an indentured servant when they enter your program and they meet criteria, if they happen to have been at work that day in an IOP capacity, right? They're getting towards maybe getting to OP and getting a lot further in the recovery. And they decide to just leave work early, go buy drugs, and go back to the property and use it, that is a reality. And what you're asking for is you want someone to be there. The problem is addicts are really, really good. And a very determined individual in active addiction has the ability to learn very quickly how to try to do something. And they might not have used on your property. They may have used on their way to your property, right? They may have stopped at a local drug house, something on the way that they know, and will have very solid functionality. And you might not be UAing them for another few hours. You might not have anything that pops up, and they might then sneak into their bedroom and an OD might happen. Now you have cameras, but not in the bedrooms due to privacy rules. So I just don't know if the on-site supervision thing, I think that might be the issue with the providers. And I think 1 to 8 might be an issue as well.
Well, let me ask you this, Tori. There's got to be on-site supervision. There's got to be supervision 24/7. Okay.
Right. Of the individuals.
Okay. So would it be better to have 24/7 on-site supervision of individuals?
Well, I think maybe what might be easier, and I'll actually use your words, so we don't over legislate. I think since FAR is really the delegated authority on this, right, legislatively and with where it is, perhaps, far as policies and procedures are better met to come up with that rather than legislate that word at all. Maybe we keep the requirements of staffing, but we let FAR dictate perhaps how that staffing is integrated into a recovery residence within the level 4. It might be the easier way to do it.
Okay, why don't we then say, and I'm hoping that that our sponsors, our legislative sponsors will accept this, but and maintains 24/7 on-site supervision at the residences, and then leave it at that and not put a ratio there at all.
Well, I think the ratio, leaving 1 to 8 as an entirety might be fine with all personnel.
Okay.
Because you're splitting both personnel, right? So you're saying 1 for 8 in the clinical staff and 1 for 8 in the behavioral health staff. That's what this says now.
Yeah,
but if you say 1 to 8 for all staff, you're generally asking for that. And I think your concern was, and it's probably a concern of other people, well, what if you have 8 clinicians and no behavioral health tech staff? So I think
and maybe okay, sorry to interrupt you, but I'll forget. Maybe then we lose the service provider personnel to patient ratio and go maintains 24/7 on-site supervision at the residences with a personnel to resident ratio of 1 to 8.
That might work.
Yeah, I deal in what can possibly go wrong. And I know that you said if somebody's wily, and drug addicts are wily by experience, not by nature, but by experience. It doesn't matter if you have somebody there, you don't have somebody there necessarily. But if you don't have somebody there, it's more likely to happen because there's less wool that you need to pull over somebody's eyes if the place, it doesn't have anybody in charge. And they're, the residence is just, hey, everybody's chill.
I don't necessarily have an issue with any of it. I was just suggesting what I think Dr. Mann was saying is that there was a concern. If you say on site, it can sometimes be difficult to maintain not the ratio of personnel. I don't think that was even the issue. I could be wrong. He might have that. Someone might have that. But I think the issue was mostly how do you regulate always on site was maybe more the issue. So I don't even think the ratio was bad. And I'll tell you, if you get the benefit of 150 residences, I don't think it's out of line to ask for a much more stringent staff to patient ratio. So I don't think you were in the wrong. I don't think any of us were for suggesting that, because you're right. If you have that many benefits of patients, you should have stringent staff requirements. You're voluntarily asking for more patients to manage, so you should have a higher bar to meet. I just think that the only issue wasn't even the ratio. I think it was the issue of the 24/7 on site and how does that get rated. And I think that as long as FAR has a strong hand in that, in their regulating that, because you don't want to not have someone be able to go with the patients is all I was saying, is what I think Dr. Mann was concerned about. So I don't think you have to remove the ratio. I think we were just worried about if you were to come to the property, let's just say, let's just make the example the reality here. God forbid something happens. An overdose happens and something happens to somebody. They're not saved, right? Do you come to the site? Does an investigation come to the site and you meet all these requirements? And an individual, for instance, had to take somebody to the hospital or to a doctor's office, or something happened where it wasn't 911 required. Maybe someone was feeling like they were having some medical issues, but not enough to call 911 because of whatever reason. And a behavioral health tech staff leaves to take that individual down the road to a hospital. And it meets the staff requirements, and you come back and somebody had used something and wasn't there when you left, but you got back and someone had come on site. So no one was there when the tech staff left, right? They left with someone, no one was at property. The tech staff gets back, someone had come on the property. And what happens to the liability then of the individuals there for an individual action? I think that was where the concern is for 24/7 on site is it is it something that was intentionally left abandoned as a flop house versus a set of circumstances created an event that an individual popped up on property when you weren't there? And I think that was more the concern, not the ratio.
Okay, all right. I'm gonna turn it over to Susan Ramsey. I have an idea also. So Susan, go ahead.
I think, once again, I'm in favor of keeping it simple, but I mean, the point is there needs to be 24-hour-a-day supervision, period, the end. So the ratio is somewhat important because of the way, at least in my experience, and I think I have some expertise on liability issues, is that there isn't enough supervision. And of course, it'll make a difference as to how many residents there are, as to how many people you need. But, you can't prepare for all eventualities, but the most important thing is that you have proper supervision. If somebody who has substance use disorder, is in the current mode of, having a reoccurring event, then, those people need to be trained. But the most important thing is somebody needs to see it, right? So this issue is really about having boots on the ground, BHTs. I don't care if they're clinical people, if they have a 1-to-8 ratio, who they are, but they need to be the people who have expertise in this kind of thing. So they can be BHTs. They can also be clinicians who are assigned, right? The most important things you have to have eyes on. And that's what I think this is addressing, because the issues have to do, the real life cases have to do with lack of supervision altogether. And that's where people, die from overdoses in recovery residences. So if you want to make this a little more streamlined, that works, but the concept is excellent and really needs to be in here. FAR also has requirements for, like how to do it, but I think unless it's in a statute, it's not going to have the power that alone. And I think it needs to be laid out like this. So, I am really in favor of this section.
Well, the upshot is this is really narrow.
Yeah.
This pertains to a large level 4 program.
Right.
Now, let me toss out some things here. I think we need to have 24/7 supervision. That needs to stay in. The ratio of 1-to-8, when you include the recovery residents, says, the whatever is going to house 150 residents, or between 100 and 150. Does that lower your ratio, say, from 1-to-8 to 1-to-6, or is it still 1-to-8? And I'm not saying yours particularly, because there are no programs like this exactly right now with that many people that I'm aware of in Palm Beach County, for sure. Is if it's a lower ratio and a 24/7 supervision without saying on-site and at the residence, and not talking about personal to resident ratio, that may be more comfortable for, again, the legislators who are going to be sponsoring this, because we're going to have some stuff coming at us on this one. It is narrowly tailored to there may not be very many programs like this. I don't know if Uta is still on the Zoom meeting, but if she is, Uta, are you aware of any programs that are this large, level 4s?
Not that I'm aware of, no. But again, I would caution to put ratios in statute. I think that's something that FAR should be putting into their, I kind of agree with your earlier point, Al, that if you have, the 24/7, and then obviously it would, the law would have to be very specific that this is for level 4s, because you don't want a level 1 to have this, obviously there wouldn't necessarily have to be any staff. So, and 1 to 8 is actually very, very, I mean, when you look at standards for, actual like inpatient and residential places, you're getting very close to that. So I don't know if that's, to me, that's something really, I've never heard of anything that big, for one thing, but I would also say that this is really something I think that FAR and their experts should look at, what the correct ratios are, under what circumstances, depending on level and so forth. That's my thought.
Thank you. Okay.
I mean, FAR did look at that. That's one of the reasons that this is in there. So I don't disagree with, the less, sometimes specificity is a bad thing, right? And sometimes it's a good thing. But, my concern for a place like this is that they're not going to have anything close to 1 to 8. It's going to be one person for 100 residents at night or something. And that's just not, enforceable.
Yeah, Al, listen, I had my hand up, but I'll just leave it at this. I think we leave the language how it is. And I think Susan's right. And this was the original intent. I was trying to have some deference towards Dr. Moran's concern about 24/7 mandated on site, but this is narrowed. It's written within the statute to affect level 4s, not 1, 2, and 3s. And so I definitely think the intent originally last year too, was to create a higher bar based on the entire metric of all the legislation here you're looking at, is really to try to correctly regulate with the providers themselves having input on this. That's why it went through so many people at VAR. So I think we leave it as it is. And if somebody wants to throw a curveball in there, they can email all of us. But I think for right now, we just leave it as that, because the narrow tailoring was the intention.
And I know, and I don't believe that Dr. Moran's program is anywhere near over 100 people, but Sam. But let me ask one thing of somebody from FAR. What's your personnel to resident ratio? Is it 1 to 12?
So generally what I've seen in my CRA coverage policy, we've always called 1 to 14. So yeah. And we do have a couple of programs. I'll have to just right off the top of my head, there's a couple in Broward, First Up Behavioral, and then Evolutions. I believe that they're both over 100 residents.
Okay. And they're over 100, so they have 2 CRRAs now currently?
Yeah, so it's the First Step Behavioral is kind of set up. It's kind of on like several blocks, but it's kind of all together different addresses, but they're over 100. So it's kind of like a compound kind of thing, if you will, in this neighborhood.
All right. We may, I'm gonna think about this, talk to Dave, and we may up the 1 to 8 for 24/7. That may be impractical. Maybe make it 1 to 12 or 1 to 14.
Yeah, so this is just something this is carried over from what has been done before. So I'll go with your recommendation on that. I think 1 to 8 overnight. Maybe I'm more comfortable, maybe 1 to 10, but I'm going to go with whatever the consensus is. Whatever you guys name it.
You guys are the experts, but Tori, you raise your hand again. And
yeah,
we need to move on because we have one more section to go.
Yeah. So if you want to manage 100 now, it's 1 to 12. It is 1 to 14 if you're at 50. And that's per level 1, 2, 3, and 4. But if you want to go to managing, regardless of what level of care, it's 1 to 12 if you want the 100 approved. There's generally 4 metrics to be approved for within how the statute was set for the prior year of last session. So 21, I believe. Wow. I'm sorry, 22. But I really don't think, and I mean, going back to and Josh says, look, I really think 1 to 8's not that bad. When you look at it, if you're voluntarily asking for 150 per CRA. So it was 1 to 10 and that would work too. But I think 1 to 9, split the difference, it's just not
10,
that.
1 to 8, if we have to, there's going to be a lot of back and forth on this between the legislation getting filed and getting passed. So I'm gonna put in 1 to 10, and And we'll leave it at that. The key is there's some significant 24/7, and we're really talking about at night. Especially for a high level of care like this, we're really talking about, at night more than anything else in early morning hours. So, okay, let's move on to our last piece of legislation to discuss. Let's see that. Yeah. Oh, by the way, I did put level 4, if you noticed at the beginning, because we are just talking about level 4s. And this is the reason we need to expand on this last piece of legislation, which is number 7, where we actually define the levels of care. And I understand that that FAR, as a certifying entity, is very much in favor of doing this. It speaks for itself in that these are basically the levels that FAR. I mean, I've had to paraphrase a little bit because I had to change the language and massage it a little bit. But these are the 4. Now let's start with number 1, with the minimum of 9 months sobriety. That's in the FAR policy or rule. Oh, I'm sorry, is that in? Yeah, that's in the FAR levels. I don't know that we can put that in there in statute. What do y'all think? Mike, go ahead.
Yeah, so I mean, I can just speak from Oxford House's perspective on that, that we would never have a length of sobriety requirement for individuals moving into an Oxford House. And then going also into the post-treatment, now the large percentage of individuals coming into an Oxford House are post-treatment, about 80%. But it's not a requirement that they are. And so if somebody is that we meet at a local Alcoholics Anonymous meeting needs a place to live, they can interview at an Oxford House or somebody in similar circumstances.
Well, here's the good news for Oxford House. The levels of care that NAR or FAR, and we're putting a statute, it has no, I don't believe, unless somebody thinks that it does, it shouldn't have any effect on Oxford House because you're a nationally recognized charter that is outside of the certification process. So
I think my only concern was that
this is going to have a ramification because it's in the definition of recovery residence. I don't think it would. We don't want to have anything that's going to affect Oxford House's existence in Florida. But again, I don't know. Let me hear from Josh.
Yeah, so thanks, Al. So Oxford houses are exempt from FAR certification. Now, currently, we've adopted, it's the NAR and the FAR level of support, level 1. They say 9 months, and currently we don't have any standalone level 1s across the state. So generally, we do have a few level 1s that are like a step down graduate house from like a level 2. If they've been there 9 months, they can move into the level 1, and it's democratically ran, and that's that. But we don't have currently any standalone level 1s.
All right. Let me put that language back there for a second. Let me posit this. Okay. Did that go back to where it was? Let me see. Yeah, okay. Here's let me go back one more. Why don't we say this? Why don't we make it the levels of care within a certified recovery residence are as follows? Because we're really just dealing with the certified recovery residences. The level 4s are certified. Oxford House, I don't want anybody to think that talk about being paranoid about a local government, somebody who, really is reading the statute and comes up with the, well, wait a second, Oxford House is not a recovery residence within the meaning of the statute. We don't want that to ever happen. So what, anybody want to comment on that? Ute, you have your hand up.
Yeah, I think that's a perfect solution because my read on this is that if you just leave it under the definition of recovery residence, it does include Oxford House, because they are recovery residences. They're they're exempted from certification, but they would still fall under this definition. So yeah, I think if you put a level 1 certified recovery residence, I think that would definitely solve that issue. Thank you.
And maybe I'll have to do an A and B here, but the staff can take care of that, the legislative staff. Okay. All right. So we have the 4 levels. We talked briefly about level 4 being an outlier when it comes to best practices because of the no clinical. But you know what? You throw it up there maybe and see how it's received. I'd like to hear some more comments though about this. I think we're going to have to put a definition of levels of care if we mention levels of care twice in the statutes. You can't do it without in a vacuum. We won't be able to pass those specifically referring to level 4 unless we have level 4 defined. So, okay, this is engendering a lot less discussion than I thought it would. Anybody else want to comment on this? Okay. Ute, you're up.
Yeah, I think my only question would be, how would this be different from day and night treatment with community housing?
Day and night treatment with community housing would be, as it always has been, a subset of every other kind of residence. Okay, so we're looking at level 4 as being anything. It could be anything IOP and above. So it would also include IOP day night without housing. It would include day night with housing only insofar as a description of what a level 4 is in terms of a recovery residence. I don't think it would affect anything to do with their licensure.
Okay, so basically this is just the definition of the housing portion, so to speak, but it could be anything IOP and above, and those would still have to be licensed just like any other service would, and none of the services would actually occur in the house.
Right. Now let's go ahead and read this a little more critically to make sure that it doesn't affect that particular license. So 30 to 37, level 4 are staffed 24 hours a day, and blend, others are level 3 is too, and blend the clinical model of licensable services into the social model to varying degrees. All clinical services are performed off-site, which is true in our level 4s. I mean, our day night with housing.
Yep.
4 residences are required to obtain and maintain appropriate outpatient licensure from the department. So
yep.
That would pertain just to the one level, one license.
Yep.
And residents are required to follow a treatment plan, attend group, individual sessions, in addition to developing a recovery plan within social model. And I think that encompasses what day night with housing does. So we should be, it just does pay attention to the fact that licenses for some level 4s are required. If the state changes their statute at some point and then does away with day night without housing and IOP has to have housing, then it'll still be, you have to obtain the appropriate license. So yeah, I think this is fine. I don't see any, it's not stepping on the license. It's not stepping on DCF. Kelly, are you still on? Do you see any issues with this? Oh, okay.
I'm here. Sorry, I was listening there. I just want to digest it a little bit more, and I was just listening to the whole thing. So,
oh yeah,
yeah, it's the level 4, and I'm beginning to understand why that is in there. One question I do have is that is that going to be referenced on a license at all?
No,
Okay, good. All right.
this is for certified recovery residences only. It's only FAR, it only involves FAR. The only thing that involves the department is that if there is a requirement for a license through the department, that
Okay.
the clinical services have to be licensed, or the
All
clinic.
right. All right. Thank you, sir. And there are, as Josh had said about there are some places, not just Evolutions, but there are a few places in Broward that do have that number of people in their residences. So, yeah.
Okay, you know, I'm gonna ask Dave, maybe we'll do a fire rescue ride along and go visit. Cause I gotta tell you, if I ever see a place like this place again, I'll definitely, Kelly, bring it to your attention.
Thank you. Thank you. Thank you very much.
Okay,
It's still with me, by the way. So thank you.
okay. Well, hey, thank you. Just thank you for, being a partner. I think we have a lot more communication between the department and not only the task force, but FAR, and I think it's really going well.
Yes, absolutely. Thank you. Thank you for having me and inviting me in this. I appreciate listening to all of this because this is really good.
Okay.
Thanks.
All right. Any other comments about number 7? I'm going to put this all together, get it to the Palm Beach County delegation. Nothing is set in stone. You know, there's going to be a back and forth. I imagine that there's going to be some pushback from the legislators on some of this stuff. There may not be. You know, I thought there would be more conversation on this last one. So it's been possible for an optimist to be pleasantly surprised. So I'll be pessimistic so far. There'll be pushback. Any other comments before we adjourn? It took longer, but we're still out of here at 3:30. Comments from the public or from our think tank folks? All right, hearing none. Hey, thank you all for doing this special meeting. Very instructive. I think there are a lot of good things happening. And we'll continue to push forward.